Welcome to QD Clinic. I'm Jack Cush with Room Now. QD Clinic is brought to you by RoomNow.live, where we give you a front row seat to what the KOLs are thinking in 2021. Today's case, RA and DVT. 47-year-old woman who has a history of DVT times 2 read something in the news the other day about some new risk for vascular disease with her JAK inhibitor. She wants to know, should we do something about that? She has a history of 2 past DVTs. She's obese. She's perimenopausal. Has no other risk factors other than rheumatoid arthritis and obesity. She has been taking a JAK inhibitor, doesn't matter which one, they all have the same risk, it seems, for 2 years now, and has been doing great. She had previously taken 2 TNF inhibitors and an IL-6 inhibitor, and on switching to the JAK inhibitor really found another level of disease control. So she's quite happy with how she's doing. The question is, does the news dictate a change in therapy? So as you all know, this has been a recent development in the last 2-3 years, that now all the currently marketed JAK inhibitors have a package insert boxed warning that basically says thrombosis, including deep vein thrombosis, pulmonary embolism, and arterial thromboses, have been described in patients taking JAK inhibitors, especially when they're used to treat inflammatory diseases. So that warning basically says there may be some risk with the JAK inhibitors, but there may also be risk with inflammatory diseases. What I want to impart upon you first is that the risk of DVT and PE and other thrombotic events is almost always primarily related to the underlying disease, whether that be nephrotic syndrome, cancer, and an inflammatory disease like rheumatoid arthritis, spondylitis, psoriatic arthritis, etc. It's almost always related to the underlying disease. In the case of inflammatory diseases, we know that the risk is clearly related to disease activity. The higher the disease activity, the greater the risk. So that's what you need to know first. Second, that there is an added risk when you start throwing in things like age and obesity. And, even better, a prior history of venous thromboembolic events. So the question for this patient again is, should she stop her current JAK inhibitor? And I think that's a discussion that has to be had. Again, she's not really at an age. Obesity she does have. She has RA, and she has 2 prior DVTs. So what is her risk? You need to know some of the numbers here. And we don't really know the additive risk. The population risk of a DVT is roughly about 3 per 1,000. The risk of an RA patient is closer to like 5, maybe 6 per 1,000. And then when you take an RA patient who has enough inflammation to get a JAK inhibitor, you add on another case or 2, so it's now like 6 to 8 per 1,000. So the added risk of a JAK inhibitor seems to be small, but it has to be on top of an existing risk for RA and for obesity and maybe other factors. So maybe this lady's risk is, let's just say it is additive in some way, and that maybe her risk is closer to 10 in 1,000 or 1 in 100. That's kind of the number that you need to talk to her about and say, does she want to risk going on to another agent and maybe being controlled, maybe not being controlled, versus an additional 1 in 100 risk for another DVT, which he's previously had. Now, of course, you would assume someone who had recurrent events has been worked up for thrombotic risk, other causes of that, and maybe she's even being treated for that. Much like the situation for hyperlipidemias with JAK inhibitors and IL-6 inhibitors, if they're already being treated for their hyperlipidemia, you're not going to see worsening of hyperlipidemia in those cases. So again, I'm talking about this case because I think it's a situation where you need to have a good, solid discussion with the patients. So if the patient's on a JAK inhibitor, has no prior VTE events, venous thromboembolic events, you can mention this, but you're probably not going to change a JAK inhibitor. Like my patient here, when she's had prior events, that's a discussion you need to have. Maybe she wants to change, maybe she doesn't. Maybe her mother died of a pulmonary embolism and she's worried about that. Maybe she's not worried about that. Again, that's a shared decision making between you and the patient. And I think it's best to know who should be on JAK inhibitors. There are certain patients, when you're starting them on JAK inhibitors, who you may not want to use a JAK inhibitor in. Someone who's older, someone who's obese, someone who has a prior venous thromboembolic event, someone who has other risk factors other than their RA, which is clearly inflamed. You have plenty of other choices in RA that you could use other agents or not. It's up to you. It's up to the patient. A reminder, this upcoming Room Now Live, March 2021, a few of our speakers, Professor Maya Book from Leeds, is going to talk about difficult RA. That's a great lecture. Michelle Petrie talking about thrombotic risk in lupus. Maureen McMahon from UCLA talking about ethnic disparities in lupus. Melody Young, a nurse practitioner in Dallas, talking about the skin exam in psoriatic patients. And Alexis Ogdi from Penn talking about the epidemiology of psoriatic disease. These and many more, Room Now Live.